Welcome to the second lecture on gait training. We wrapped up the first lecture talking about the 8 subphases of the gait cycle. We can break down the gait cycle into the stance phase, which makes up about 60% of the gait cycle, and the swing phase, which makes up about 40% of the gait cycle. If we quickly review the 8 subphases, we'll start out first with the 5 subphases that are part of the stance phase of gait. First is initial contact. In normal gait, this is when the heel of the lower extremity strikes the ground. The second subphase is the loading response, also called foot flat. This happens as the foot is lowered to the ground and the weight is actually transferred to this leg. The third subphase is the mid stance. This is when the trunk progresses from behind to in front of the ankle. The fourth subphase is terminal stance, also known as heel off. This is when the trunk continues to move forward and the heel comes off the ground. The fifth and final subphase of the stance phase of gait is called pre-swing or toe off. This is when the body weight is unloaded from this limb and transferred to the other limb. This subphase ends as soon as the toe comes off the ground. As the toe comes off the ground, the 3 subphases of the swing phase of gait begins. The first one, which makes up the first third of the swing phase, is called initial swing or early swing. What happens during this subphase is that the limb is lifted from the floor using hip and knee flexion and ankle dorsiflexion, which allows clearance of the foot and advancement forward of this swinging leg. The second subphase of the swing phase of gait is called mid-swing. This is when the knee begins to extend, the ankle achieves a neutral position, and the leg actually moves past, the swinging leg moves past the stance leg. During terminal swing, which is the third and final subphase of the swing phase of gait, this is the point where the knee starts to achieve maximal extension and the ankle remains in a neutral position as this limb prepares to take on the weight of the upcoming stance phase of gait. I highly recommend you stop the video at this point and review those 8 subphases as you actually practice walking yourself. See if you're able to say the names and kind of state what's going on during each of those subphases. At this point, we'll resume kind of lecture moving along in our PowerPoint. And this slide is really talking about all of the things that are required of people who want to walk. So first thing, kind of you need to have both equilibrium and locomotion. Equilibrium is just kind of a fancy word for being able to remain upright and keep your balance. And locomotion is just talking about the ability to initiate and maintain the rhythmic stepping needed to advance yourself. Other contributing factors that allow us to be able to walk are functioning of our muscles. We need both flexibility and strength within our muscles. The bones need to be able to move to allow joint mobility. We need to have adequate strength and endurance in our muscles, as I mentioned earlier. There has to be enough tone also in our muscles. And when we're talking about muscle tone, we're really talking about a kind of unconscious low-level contraction that our muscles have even while they're at rest. Muscles have to have enough tone to resist gravity, but low enough that they allow movement or stretching of the muscles. To be able to walk, we also need an arm swing. As you're probably aware, as your right foot moves forward, it is actually your left arm that also swings forward. This allows us to remain balanced. There's a counter rotation of our trunk and pelvis that are produced that allow the arm swing, and this keeps really the mechanical system in balance by having the one arm forward when the other leg is forward. We also need sensory systems such as vision, vestibular, and sensory motor or proprioceptive systems to be able to really take information in and allow us to remain in an upright, balanced position. We'll talk a lot more about these contributing factors throughout the program, but just kind of want you to be aware that there's a whole bunch of things that are necessary for a patient to be able to walk. So really, it can be problems in any of these specific areas that can lead a patient to come to us due to gait abnormalities. We're going to move on now and talk about different weight-bearing status terms. If you remember, weight-bearing status is the amount of weight a patient can put on involved leg or legs. So, I guess first thing I want to say is just that weight-bearing status is always determined by the physician. We don't determine weight-bearing status of our patients. So if your patient has had an injury or a surgery in their lower extremity, you should look for a confirmed weight-bearing status to make sure that you aren't going to instruct your patient to put more weight on a lower extremity than they should. So there's many acronyms that we use to identify weight-bearing restrictions or weight-bearing statuses, and you'll see them listed here on this page of your slide. So go ahead and see if you can imagine, maybe you want to pause the video and see if you can figure out what each of these might stand for. What do you think each of the acronyms stand for? Go ahead and pause it now. So maybe you were able to identify some of these. FWB stands for full weight bearing. This is the same as TWB, which stands for total weight bearing. Both of these mean the exact thing. They mean that the patient can bear their full weight upon the extremity. So during single limb stance, all of the patient's weight is on one leg. When a patient is full weight bearing or total weight bearing, it means there's no restriction. During single limb stance, they can put all of their weight on that one leg. WB stands for partial weight bearing. What this means is that a patient can only put a certain percentage of their weight on that leg. When a patient is partial weight bearing, more information is needed. Is it a certain amount of poundage that they can only put on, or is it a certain percentage of their body weight? A physician has to give you more information than just partial weight bearing to be able to instruct your patient in this type of weight bearing status. Usually what we do to help people kind of feel how much, maybe if their partial weight bearing status is 25 pounds, what we do to actually help them feel what 25 pounds on that limb feels like is we actually have a scale in most clinics. And we usually have them kind of go into the parallel bars. Maybe you're familiar with parallel bars. They're two kind of bars that run that patients can bear their weight on. So kind of each of their hands are on one of the bars, and they can practice putting, we put the scale underneath the leg that has the partial weight bearing restriction, and then they actually step on the scale, holding part of their weight on their arms on the parallel bars, and the other portion of their weight is through that leg which is on the scale, and then of course their other leg has to be in the air so that they can really assess how much weight is going through that leg with the weight bearing status. And then you can help a person kind of learn what it feels like, for example, to put 25 pounds on that involved extremity. WBAT stands for weight bearing as tolerated. And this one is really common, so I want to take a little bit of extra time talking about this one. This one is saying that the patient is actually able to bear full weight if they want, but they should only bear as much weight as is comfortable for them. Weight bearing as tolerated encourages the patient to put as much weight as they can on it because this actually can enhance healing. But if it's either too painful or if the limb becomes weak when that much weight is on it, they'll need to take some of the weight off by using an assistive device. So weight bearing as tolerated can be described, when I describe it to my patients, I always say, you can put as much weight on that leg as you want or as much as is comfortable for you. A little bit of pain is okay, but if it becomes too painful or if the leg starts to give out or becomes weak, you'll want to take a little bit more off of that limb and instead put it on your, crutches or on your walker, whatever the patient's using. NWB stands for non-weight bearing. When a patient has a limb that is non-weight bearing, this means absolutely no weight is to go through that leg. And what that means is that the patient actually has to keep that limb up and off the ground while they're walking. So they actually have to flex the knee and the hip to keep it up and off the ground during weight bearing. And instead, they have to use either a walker or crutches and use those assisted devices to take the weight off of that leg when that limb is, supposed to be in the stance phase of gait. So even with that one, a lot of times patients will say, well, can I at least put my toe down for balance? And the answer is no. When someone is non-weight bearing, they can't even put their toe down. They need to have their entire limb lifted off the ground. If they can put their toe down, it's going to be the next type of weight bearing status, which is TDWB or TTWB, which stands for toe down weight bearing or toe touch weight bearing. What this means is that the physician doesn't want the patient to actually put weight through that leg, but the physician is okay with the patient resting their toe on the ground. This is really helpful because it can really enhance the balance of the patient, and it also makes it a lot less work for the hip flexors and knee flexors. They don't have to kind of hold that limb in a flex position while they're walking. So it's a lot more comfortable for the patient. Again, no weight through the limb, but they can have their toe touching the ground, again, to help with balance. In this particular unit in lab, we're going to be working on gait training using axillary crutches. Most of you, I'm sure, have seen axillary crutches. Maybe some of you have even used them yourself. Axillary crutches can also be referred to as regular or standard crutches, and they're typically made out of aluminum, although an older style used to be made out of wood. If we talk about the parts of the axillary crutch, we can talk about the axillary bar or the axillary pad. So that's this portion up here, which is located when a patient uses them in the armpit area. There's also the hand piece, which is this piece right here, which obviously the hands hold on to. When we talk about the hand piece, we can actually move it up and down along the double upright. There's a screw and a wing nut with sometimes there's a washer as well that allows us to kind of unscrew this and move this to the appropriate height. We'll talk about what the appropriate height should be when we get into the lab portion. You'll also notice these double uprights, which are joined distally here and then into a single point tip, which is then covered with a rubber suction tip. So that's what you should notice right here. Axillary crutches come in different sizes. There's 3 different adult sizes typically, which allow it to be increased in height to up to 60 inches. There's a spring button that allows you to change the height of it. And then there's also smaller crutches that are available for children. At this point, I'd like to end the lecture talking about 8 different types of abnormal gait. I'm going to show a video while you guys actually continue looking at your PowerPoint. So what we're going to do is we're going to go through these 8 different types of abnormal gait. Throughout the program, you're going to learn more about these abnormal gait types, as well as a few others, but these are going to be the 8 most common types of gait abnormalities that you will see in your patients. So just give me a second. I'm going to go ahead and go to the video. Sorry, couldn't find where it was. All right. So if we go ahead, let me just pause it here so that I can get my screen organized. All right. So if we talk about the first of the 8 abnormal gait patterns, we'll start with talking about what is called the foot slap. gait. Let me start the video as I'm doing it here. All right, so with a foot slap type gait, when the patient heel strikes, you'll see that the foot rapidly slaps down right there. And this is usually due to weakness in the dorsiflexors. So you can watch it here. There's normal. And then on this side, it's going to slap down very quickly. And this is, again, usually due to weak dorsiflexors. So normally the foot slowly transitions from a dorsiflex position to a plantar flex position. But this eccentric contraction that has to take place in the dorsiflexors can become problematic if the patient has weakness in the dorsiflexors. You'll actually sometimes hear a slapping sound as the patient walks with a foot slap abnormal gait. The second abnormal gait is called sapage gait or high stepping gait. This you'll notice during the swing phase right there. She pauses it there. During the swing phase of gait, the patient does excessive hip flexion and knee flexion. And this is, again, usually due to a weakness in the dorsiflexors. Because the dorsiflexors aren't flexing the foot to be able to clear the ground, it looks like a patient is stepping over some imaginary obstacle. But they do this to try to make sure that the foot clears the ground. So again, there's excessively flexed hip and knee to allow for the foot to clear the ground, usually due to a weakness in the ankle dorsiflexors. The third abnormal gait is called vaulting gait, and this occurs during the single limb support portion of stance. The ankle actually plantar flexes, so the patient kind of goes into an on the toes type position. We can see it right here. And they do this, they kind of vault up to try to clear the other foot or toe in the swinging leg. So they vault up or kind of go into an up on their toes position during stance phase on the one leg to try to clear the other leg. So maybe the other leg can't flex at the hip or knee, or maybe the foot is weak and there's, they can't dorsiflex, but for some reason, to give a little bit more clearance, the patient has assumed the abnormal kind of pushing up or vaulting during the stance phase to clear the other foot. The next gait, abnormal gait, is called the forward lean. And what you notice with this one is that during the loading response, the patient right there forward leans. And they typically do this due to weakness in the hip extensors, or sorry, the knee extensors or the quads. So right there during the stance phase, so the patient has weakness in the left quad, the patient leans forward. So there's excessive forward trunk flexion. And what this leads to is that the knee actually goes into genu recurvatum, which is kind of a fancy word that means excessive hyperextension of the knee during that stance phase of gait. By doing this, by leaning forward, it moves the line of gravity anterior to the axis of the knee, locking the knee in extension. This really works to help reduce the muscle activation that's needed in the quad. So when a patient has weak quads, they can compensate for the weakness of the quads by leaning forward, pushing the knee into kind of a locked genu recurvatum or excessive hyperflexion knee position, kind of locking it out so that the patient doesn't, have a knee buckle and a loss of balance. So here's another example of genu recurvatum gait, which is, again, hyperextension of the knee. Sometimes patients have this due to a plantar flexion contracture as well. So we'll watch just a little bit more of here. We have the hyperextension of the knee. This can lead to an overstretched posterior capsule, which is not good. So we want to try to combat this deviation if at all possible. In the next abnormal, we're going to look at weak hip abductor gait, also called Trendelenburg gait. And as I mentioned, this is usually weakness in the hip abductor muscle, most commonly the glute medius muscle. At first, we'll look at if it's uncompensated, you'll see a shift when the patient is standing on their weak side. In this case, it's the woman's right side. So when she stands on that right side, when it's that right side is in single leg support, you'll actually see the patient lean away from this side. So she's leaning toward the left because her right hip abductors are weak. And this is called uncompensated Trendelenburg gait. Sorry, I just realized I missed the R in your PowerPoint. So it's not Tendelenburg, it's Trendelenburg, sorry. So again, this is the uncompensated, which is a lean away from the weak side when the patient is standing on that weak side, the side that has the weak abductors. Compensated Trendelenburg gait looks like this. So instead of leaning away from the weak side when the patient's standing on that weak side, they actually lean toward the weak side. This shifts the line of gravity and reduces the demand on those hip abductor muscles. So by shifting the weight, in this case, the woman shifts to the right, she's shifting her line of gravity, which reduces the amount of muscle activity that's required by the hip abductors, which are weak on that right side. So this was called compensated Trendelenburg gait. The next one is the backward lean or gluteus maximus gait. This occurs when the patient has weakness in the glute max or the hip extensor muscles. The patient shifts their center of gravity backwards during the stance phase to accommodate for the lack of muscle stabilization of the glute max or the hip extensors. So here is it in slow motion. You'll notice she leans posterior, which shifts the line of gravity posterior to the hip, reducing the muscle activity that's required by, right there, required by the glute max or the hip extensors. You'll see this in polio patients sometimes. Right there, she shifts backward during the stance phase of gait to take away some of the needed effort of the weak glute max. The next deviation is called hip hiking gait. Hip hiking gait is when there's a shortening of the swing leg by hiking or elevating the hip during swing phase. So you'll see that's the weak side. She elevates the pelvis on that side, and this is usually done to compensate for a lack of hip or knee flexion or ankle dorsiflexion as that leg swings through. So normally you flex the hip, the knee, and dorsiflex the ankle to try to clear it. But if for some reason maybe the patient has a knee immobilizer on, maybe they have pain in their hip or knee or ankle, if they can't bend those joints to clear it, they can compensate by hiking or elevating the hip. So that's what you see here. The last compensation is really done kind of similarly or for similar reasons as hip hiking, but it's called circumduction. She's doing it on the other side. But again, if the hip, knee, or foot can't flex, the patient can, instead of elevating the hip, they can circumduct the hip. So what they do with this is they do kind of a circular motion or kind of make a semicircular arc. This creates extra clearance for the leg that is kind of extra long because it's not flexing at the hip, knee, or ankle. So you sometimes see hip hiking gait used in association with vaulting. So they'll vault on their stance leg and they'll circumduct their swinging leg. So that concludes the lecture on abnormal gaits, as well as concludes the lecture on gait training.